I would like to introduce Allison Ross, the Director of Knowledge Mobilization with Ovarian Cancer Canada, who will be facilitating our first two sessions this evening. Welcome, Allison.
Thanks, Steph. So recurrence is a topic that comes up frequently in conversations with women living with ovarian cancer. So in this next session, Dr. Lesley Roberts, Gynecological Oncologist at Cancer Care Manitoba, will be joined by Teal's sister, Terri McGraw, who will share her knowledge, lived experiences, and tips to manage recurrence. Terri lives in Winnipeg and loves spending time with her family and friends. She is a nurse by profession, and she's looking forward to navigating this difficult subject of recurrence in the journey of living with ovarian cancer. So over to you both.
Thank you very much. Just give me one moment. I'm going to share my screen, and hopefully that is now visible for everyone. So the way we decided to structure this is that I'm going to give a very short little talk about recurrence from the gyne-oncology perspective and what we think it's important for people to know. And then Terri and I are just going to kind of chat about questions that have occurred to her and to other people who are in similar situations. And then hopefully we'll leave enough time at the end that anyone in the audience can ask questions. So I'm sure this is going to be news to absolutely no one, but I think it's important when we're talking about recurrence to just have a little bit of background about ovarian cancer in general. So there are multiple types of ovarian cancer, and I'm sure not everyone on this call has the same type of ovarian cancer. Most of what we talk about when we talk about ovarian cancer, and most of what I'm going to be talking about, is what we call high-grade serous ovarian cancer, which is the most common subtype, but there are differences depending upon what particular type of ovarian cancer you may have. Typically, ovarian cancer is going to present with an advanced disease, so that's what we call stage 3 or higher. And the overall 5-year survival, which is what most oncologists use when we talk about survival, that varies by stage. But we know, generally speaking, that the rate of survival, so your overall likelihood of survival, is going to decrease as your stage advances. And as a result, we know that the rates of recurrence end up being quite high for ovarian cancer. So it can be up to 80% in advanced stage ovarian cancer, again, depending upon the stage that you have and the particular type of ovarian cancer you have. But it's quite common. So I think this is a very important topic to discuss because it is so common. So before we get into it too far, I wanted to present a little bit of a glossary of terms. Now, these are not specific, and I apologize if you can hear mumbling in the background. I'm still at the hospital and they call codes every once in a while. But generally speaking, I've had a lot of people talk to me, a lot of my patients talk to me about why don't I use the word remission? They want to hear that word. It's important to them. It's not a word that we typically use in ovarian cancer. You are going to hear very few gyne-oncologists use the word remission to define where you are in your disease. What it means is that there's no evidence of any active cancer. So any scans or tests or anything like that do not identify cancer, but it implies that there's the expectation that your cancer is going to return at some point. Remission implies kind of a break, but it's going to come back. And the reason we don't commonly use it in ovarian cancer is because the primary treatment, the treatment that you get when you first get diagnosed, that treatment is curative in intent. We are hoping that this cancer never comes back. We know that it might, but the goal is for cure, and therefore we don't tend to use the word remission. Words that you may hear instead are no evidence of disease, which means that we've looked with scans, we've done exams, we've done blood work, and there's no active cancer to be found. This is often something that we talk about also after surgery when we've been in the belly and there's nothing left that's visible. Or people might use the phrase cancer-free, which means there's no evidence of any active cancer on imaging, clinical examination, or blood work. And this is usually what we'll talk about post-primary treatment when we're still aiming for a cure. The problem with a cure is that I cannot tell a patient that they've been cured until they've proven to me that they are, which means they've gone 5 years with no evidence of any disease coming back. So it's kind of difficult to tell someone up front that they're cured because I won't know that for 5 years still. So we use the phrase cancer-free. But what specifically is recurrence? And this can be tricky sometimes to understand. So from an oncology perspective, from a physician perspective, recurrence is evidence of active cancer following a period of time with no evidence of disease. So you managed to have negative CT scan, normal CA-125, clinically well for however long that may be. That could be a month, that could be 5 years, and then the cancer comes back. That would be a recurrence. That's different from progression, which is evidence of growth of cancer that we know is there, either on or off treatment. So some women will stop chemotherapy because they've gotten a maximal response, so there's no more shrinking of disease, or we don't see any disease on CT scan, but a CA-125 is still a little bit elevated, which makes us think, well, maybe there's something there, but we're not getting anything more other than more side effects with chemo, and so we stop. If that were to develop further, if the CA-125 were to rise or you were to get symptoms, that would be considered more of a progression than a recurrence because there was never any true cancer-free time. So those are the phrases or the words and what we mean by them when we talk about recurrence. And this talk was sort of geared towards, in general, how we monitor for recurrence. So this is mostly for the patient who's done treatment, who is currently off treatment. What are we doing now? How are we monitoring? So in Canada, the recommended mode of monitoring for recurrence is clinical. And what that means is that there will be a symptom assessment. So someone will ask you a whole bunch of questions. That can be a nurse, that can be a physician, and there will be a physical examination, typically checking your abdomen, doing a pelvic exam, looking for any concerning symptoms or findings. And that will usually occur every 3 months, although as you get farther away from your initial treatment, those visits may be spaced out. If there's any concerning findings on the symptom assessment or exam, that is when we would move towards doing some investigations, typically a CT scan or blood work. Usually, in most centers across the country, there will not be routine CT scans done with every visit. That's pretty uncommon, and it would be fairly specific situations in which you would be getting, say, an every 3-month CT scan. CA-125 is a little bit different. That varies very much across the country. It varies based on what type of cancer you have, what the particular nuances of your cancer were. So CA-125 standardized is a little bit trickier, but we are going to talk about it because it is something that people ask about fairly frequently. So CA-125 monitoring, what is the evidence for doing it? Or as I say, the lack thereof, because there isn't really an awful lot. So in Canada, the guidelines that physicians follow for monitoring ovarian cancer recommend against routine CA-125. So they say, do not do this every 3 months, every time you see a patient. In Europe, they also recommend against doing a routine CA-125. In the US, they say you can consider it to monitor for recurrence in discussion with a patient. And as most of us know, the US tends to be a little bit more intervention forward. They do a lot more with perhaps less indication. It's a different style of healthcare practice. But what actually is the CA-125? Why do we care about it? Well, it's what we call a tumor marker, which means it's a protein that's found in the bloodstream that tends to be elevated when you have a cancer. So 80% of ovarian cancers will be associated with an elevated CA-125, not all of them. However, the tricky thing with an elevated CA-125 is it's not necessarily only caused by ovarian cancer. It can be, but it can also be caused by having your period, by having intra-abdominal infection or inflammation, if you have liver failure, if you have heart failure, a whole bunch of things can cause this. We've been seeing over the past 2 years a lot of elevated CA-125s with people who get COVID, for instance. It's been throwing off our numbers quite significantly. So it's not a great test. It's what we have, but it's not a great test. So the evidence, the scientific evidence behind this originally started in the 1990s, where primarily in Europe, they did some trials and they found that the CA-125 rises about 2 to 5 months before clinical signs or symptoms of a recurrence. So you would be asymptomatic, they would find an elevated CA-125, and then they actually watched to see what would happen. And several months later, it would be found that someone had a recurrence. And they noted that you needed to double the upper limit of normal. So depending upon your lab, that is slightly different, but it usually lands somewhere between 30 to 40 is the upper limit of normal for a CA-125 value. And in order to accurately predict a recurrence, that would have to go up to double that. So 60 to 70 in that range. A little tiny bump was not accurate in terms of predicting recurrence. So that's also important to keep in mind when we're thinking about CA-125 and how we interpret it. In 2010, there was what we call a landmark trial, which means that it was a very important trial that actually changed practice. And it was a randomized clinical trial, which is the best type of scientific evidence we can have. It looked at 529 women with ovarian cancer, and they had CA-125 monitoring following completion of their treatment. So they had no cancer, active disease, and they were just having this CA-125. There were two groups. The first group, as soon as that CA-125 started to go up, they started chemotherapy. The second group, the CA-125 went up and they delayed the start of any chemotherapy until they developed symptoms. So they waited, they didn't start with that CA-125 value. They started when they had symptoms of recurrence. And they found that there was absolutely no difference in survival between the early group and the late group. So it didn't seem to matter in terms of how you did from an overall cancer standpoint, whether you started right away or whether you started later. But what they did notice was that women reported that their quality of life was worse when they had the early treatment start. So when they started as soon as that CA-125 result went up. And on the basis of this, most physicians think that the CA-125 is not helpful, because figuring out that you have a recurrence early doesn't seem to change your survival, but it does seem to make people overall have a worse life. And that's not what we're going for. We obviously want people to live as long as possible, but we also want them to live as well as possible. So the impact of early diagnosis of recurrence is basically that there isn't one, honestly. So there's no survival benefit seen with an early diagnosis and treatment of recurrence. So when I say early, I mean prior to developing symptoms. There's no benefit. There's no improvement in what we call progression-free survival, which is different than overall survival. Progression-free survival is essentially the time where you're cancer-free. So it's basically the time between when your cancer treatment ends and when the cancer comes back, if it's going to. That also didn't change whether you started your chemotherapy immediately upon a CA-125 rise or later. But again, we know that the quality of life decreases with early diagnosis and treatment of recurrence. So what is the CA-125 actually useful for? Well, it's great for helping us diagnose an ovarian cancer. If you present with a pelvic mass or all of the ascites fluid, a CA-125 is useful in telling us where that might be coming from. And if you had an initial CA-125 rise with your diagnosis, we can use it to monitor response to treatment. But it's not very good for monitoring for recurrence. That's essentially the bottom line here. The timing of your treatment, when you start treatment for recurrent disease, is also something that gets talked about a lot. So the timing of treatment, I'm going to put in a caveat here, it's very subjective and it varies with every patient. Every doctor-patient relationship is going to have a different rationale for timing. However, there is no survival benefit associated with starting treatment early prior to developing symptoms. You do want to initiate treatment typically with the development of symptoms because A, you're going to make someone feel better, and B, if you wait really long, like if you let symptoms grumble and grumble and grumble and grumble, it's possible a person could get too sick to get chemotherapy. So usually we don't want to give people chemotherapy or any treatment when they're feeling well and have absolutely no symptoms. But once they start getting those symptoms, we would stop. So those can include abdominal symptoms, respiratory symptoms. And I also talk to all of my patients about the fact that anxiety around the fact that you may have cancer or that you know you have cancer and we're not doing anything about it, if that's significantly limiting to you, that counts, to me anyways, as a reason to start treatment. So one of the questions I can ask is, what follow-up can you expect? This was one of the questions that I was asked to answer. And again, this is going to vary significantly across the country. I can't tell you exactly what your oncologist is going to do. What I'm going to talk about is a general model, overall what you should expect. So typically, as I said, you're going to have a routine physician or nurse practitioner assessment every 3 months, and that will include a history of any symptoms that you might have and a physical exam, ideally involving a pelvic exam. Now, I recognize that this has changed in COVID. We are doing in Manitoba, we're doing a lot of virtual visits, and I suspect that that's true other places as well. And they've actually done studies in the US throughout the past 2 years over COVID to see Have outcomes from ovarian cancer gone down with this switch to virtual visits? Are we missing recurrences? And it turns out we're not. So we're certainly not providing any worse care because we're doing this. The ideal is to do a physical exam, but we do seem to be able to safely get away from it, at least in times of pandemics. Investigations with blood work and imaging will be done if there's any concerning symptoms or physical examination findings, but typically routine scans and blood work are not going to be done in follow-up unless there's a specific indication. Now, as I said, that can vary. Different centers are going to do things slightly differently, but by and large, routine CT scans and CA-125s are not going to be done in follow-up, because as we discussed earlier, it does not seem to improve survival and it does seem to decrease quality of life. And that is what I have from a more sort of educational standpoint. And we're going to move into the conversation part, and I'm going to try and figure out how to stop sharing my screen so you can see Terri and myself on the screen.
Thank you, Dr. Roberts. Before I ask my first question, I'm just going to tell you a little bit about myself. I'm Terri McGraw, and I was first diagnosed with ovarian cancer and had my surgery in April of 2021, stage 3B, mixed cell type. I had 6 rounds of chemo like everyone else, did well with all of that. And at 3 months, I had a couple of symptoms, was given a CT scan, which did come back, no evidence of disease. I worked towards going back to work. At 9 months, had another CT scan because it had a couple of symptoms. And unfortunately, this one came back showing that I was in a recurrence. Completely new world for me. I had really no idea how to navigate. And so that's kind of where I'm at right now, going through treatment and still trying to figure this out, but also encouraged that I have met women like Crystal and some others who are living quite well with ovarian cancer. And so having a recurrence, as hard as it is, doesn't mean it's the end. So that's one of the reasons why I'm excited to be here tonight to kind of navigate this. So one of my first questions is, Dr. Roberts, when we have mild symptoms, at what point in time should we be contacting our healthcare team? We don't want to be constantly thinking about it and constantly calling our staff. So when should we?
That's an excellent question, and I get asked that question a lot. And what I typically tell people, there's no right or wrong answer. So if you are very worried and you're perseverating, call. Right? It's always better if this is weighing on you to call and ask someone. And we are here to support you. People often express this idea that they're worried about contacting the healthcare team too much. That's not a thing. We're okay. It's fine. Call us as often as you need. But in terms of when to be worried, what I typically tell people is any symptom that's new that you haven't had before, that's persistent and gradually increasing over 2 to 3 weeks is something that your healthcare team should know about. And that can be any symptom, because ovarian cancer can come back anywhere. But the bottom line is that it's not something that's there for a day and then goes away, because everyone's going to have a day where you ate something you shouldn't have and your bowels feel kind of yucky and you get bloated. And if you have a history of ovarian cancer, that twigs something for you, right? And then it goes away again. So you want something that's progressive and present for a while before you contact.
Mm-hmm. That I've been advised that as well. And one of the things that I do is keep a journal of the dates that I have symptoms, so that when I do call the doctor, I know exactly when they started and how long they've been going on. So if a recurrence is diagnosed, how do we decide when to start treatment? And I guess I'm thinking diagnosed, I would imagine, based on symptoms, since we don't routinely do CA-125s. And sometimes there's more than one treatment option. So how do we decide which to do? What do we ask our doctors about that?
Also, excellent question. So again, this is going to be different for every patient and it's an individual discussion, but overall, the goal of recurrent treatment is to improve. I mean, ultimately, we want you to live as long as you possibly can, but really the goal of recurrent treatment is to make you live with your cancer as well as you possibly can. So if you feel like you are coping and the symptoms are mild and you had a really hard time with chemotherapy the first time around, for instance, like it just made you feel really unwell, then typically I suggest to people that they delay. If, however, the symptoms from your recurrence are really bothersome, whether that's thinking about the recurrence and worrying about the recurrence, or whether that's actually physical symptoms, that's when I tell people to go on treatment. As you say, there's lots of different treatments, and what treatment is recommended often will depend upon the time between when you finished your last treatment and when you recurred. We have a 6-month mark that we use a lot in oncology that guides what treatments we're going to use, but most of the time it's going to be a chemotherapy option that we recommend.
Okay, and based on your talk earlier, it sounds like if we do decide to delay for a little while because our symptoms aren't severe, it doesn't actually affect our overall survival. Is that right?
That is absolutely correct.
Okay. Now, if our second line treatment results in a reduction of the disease, but we don't come to a complete no evidence of disease, how do we decide at that point whether we should continue treatment or we should take a break? And then when should we resume?
Excellent question. So ideally, if someone is tolerating chemotherapy, they're doing well. I mean, I recognize that chemotherapy is not pleasant, but if you're having a bad week and then the rest of the time you're doing okay, we typically recommend treating to what we call maximum response, which essentially means treating to the point at which we're no longer seeing any decrease in CA-125 or shrinking on a CT scan. So when we get to a point where your CT scan, say post cycle 6, is exactly the same as your CT scan post cycle 9, that's what we would consider maximum response. Nothing's changing anymore. Now, the cancer is still presumably responsive to the chemotherapy because it's not growing, but it's not changing anymore. So at that point, we will often consider stopping treatment for a little while. And that will usually be what we call a treatment break, because we anticipate if there's still cancer there, we know that off treatment, eventually it will start to grow again. That's unfortunately what cancer does. Without any treatment, it grows. So a treatment break, a standard length of treatment break is going to be about 3 months, because as I'm sure many of you have noticed, oncologists really love groups of 3. It's our magic number. And so usually we'll reassess at 3 months. If you're still feeling well at 3 months, we'll go another 3 months. But then once you start to develop those symptoms again, once you notice the cancer growing, that things aren't feeling right anymore, whether that's 1 month after stopping or whether that's 12 months after stopping, that's when we would consider restarting treatment again.
Okay. I guess what questions should we be asking our oncologists at this point to help us decide how to move forward? I mean, in terms of, I guess, about our disease itself, what should we be asking?
That's a good question. I think it's always important to ask what happens if you take treatment and what happens if you don't take treatment. I think those are 2 very good questions, and I find a lot of people don't ask the what happens without treatment, or at least without treatment right now question. I think people often feel pressured perhaps by the oncologist into starting chemotherapy when they might otherwise not. So asking, what to expect with treatment right now versus what happens if I wait, I think that's a very important question to ask. And then being upfront, particularly if you're finding chemotherapy really hard, asking, can I stop? What happens if I stop now? Is there an opportunity to take a break?
Okay, that's helpful. Thank you. If we wanted to seek or pursue some alternative therapies, along with continuing our relationship with our gynae oncologist, is there a way that we can do this in cooperation? It doesn't seem very easy in Manitoba.
Yes, it's not very easy in Manitoba. You're correct. So there's a little bit of a hard line in terms of when you're on chemotherapy. A lot of the alternative treatments that are medication or supplement based will interact with chemotherapy. So common ones that we see are vitamin C and mistletoe are often used, and those actually interact with chemotherapy in a way that makes the chemotherapy less effective. And so we will often ask people to not use those particular alternative treatments while on chemotherapy, because if we're going to use chemotherapy with all of the risks and the side effects associated with it, we want it to be maximally effective. Now, outside of that, and I cannot speak for all providers, but outside of being on active treatment, I am happy to continue to see people and support people and symptom manage if they're on alternative treatments, but I don't personally have the expertise in them. And that's going to be true, I suspect, of most oncologists. Western medicine does not train us in naturopathy and homeopathic medicines and things like this. We just don't have the knowledge. So certainly seeking that out yourself and seeing someone and working with them, I have no problem with that. It's always very helpful if you let your oncologist know what alternative treatments you are using. Sometimes I find that doesn't happen, like that discussion perhaps is not as open as it should be. So that discussion I think is very important. But unfortunately, based on the way our medical system is built in terms of supplements and homeopathic and naturopathic treatments, most of those are going to be patient-led. Some alternative treatments in terms of symptom management, like physiotherapy, acupuncture, things like this, referrals can be written by your oncologist for those services, and depending upon your insurance, that helps get coverage and things like this. And we're very happy to be involved in that aspect of things. It's not that we don't want to be involved in naturopathy, we just don't know anything about it, really, is the honest answer to that question.
Okay, thank you. I appreciate that. Now, this last couple of questions are a little bit harder, I guess, to think about. At what time should we be expected to be asked or start thinking about a do not resuscitation order on ourselves?
So working in oncology, I think I probably have a very different approach to this than most. I think everyone at every point should think about what their goals of care are, regardless of whether you have cancer or not, and should document those. I have pestered my parents more than you can possibly believe to tell me what their goals of care are, and neither of them have cancer. So that's my bias. I think everyone should be having that discussion, regardless of where you are in your cancer journey. In terms of when you can expect to be asked by your physician about that, most of the time that's going to be at the time of recurrence. Maybe not your first visit, because there's a lot of information at that first visit, but somewhere in that initial treatment of recurrence, you can expect an oncologist or a member of the team to ask you about what your goals of care are. Part of the reason for that is because we know that ovarian cancer is essentially, once it's recurred, it's like a chronic disease. It's not going to go away. You're going to live with your ovarian cancer, and you may live very well and for a very long time with your ovarian cancer, but you're going to live with it. It's going to flare up. It's going to go away. It's a part of your life. And in that setting, when we know we can't cure it, we can't make it go away permanently, most of us want to bring up the conversation of, if you got really sick with a cancer that is going to be with you now forever, what do you want us to do? There's no right or wrong answer. That is a personal decision for sure, but that's usually about when we would bring it up.
So in terms of planning maybe advanced care directives or advanced healthcare directives, are there supports available to help us to do that? Because we don't all understand all the terminology, or what should happen if I have a heart attack as opposed to have a flare-up of a cancer situation, which could have different outcomes. So, yeah.
So this is something that's a bit difficult for me to answer, because advanced care directives and goals of care and how that's done varies significantly province by province and hospital by hospital. But broadly speaking, yes, there's going to be resources wherever you are. Social work is often a good resource. Most cancer care is going to have, whether it's psychosocial oncology or a pure social worker, will have that available. Most cancer care centers also will have essentially a booklet or a guide that's supposed to help guide a patient through advanced care planning. And I encourage you to ask your oncologist if they have something like that. And if so, can you have a copy of it? I know we have one in Manitoba. I've worked in other places across the country which also have them. So I think that's reasonably standard. It might not be cancer specific, but it would be hospital specific or province specific. And certainly if you feel like you're struggling or you don't understand the terms or you want a little bit more information about it, just ask for something like that.
Okay. This particular question has been kind of on my mind some, and I know as a nurse, it's a good thing to think about, and that everybody, whether you're healthy or not healthy, should be doing it. But sometimes having had a diagnosis, it feels a little bit different. And so thank you for that guideline. It does help. Making these plans does not make us die faster. We are all going to someday. It just helps maybe give us a little bit of peace of mind knowing that our family knows what we want.
Exactly.
So I actually don't have any more questions for you, Dr. Roberts. And I see that we still have some more time. So Allison?
Yes, I'm here. So thank you both for addressing these really common and these really difficult questions about recurrence. We actually have a lot of questions from the audience coming in, and I just want to set some expectations. We're not going to be able to get to all of the questions. We're going to do our best to kind of group some themes together, and then we can also follow up and try to get more questions answered and get you all that information. So one question I was hoping we could get answered is symptoms to watch for. Are they unique and specific to the individual or generic for most types of ovarian cancer?
So I would say broadly speaking, they're fairly generic. Most commonly we see, similar to the presentation, sort of vague abdominal symptoms. So increased bloating, lack of appetite, changes to the bowels, whether that's increasing diarrhea or increasing constipation, sometimes some vague abdominal pain. That's probably the most common. Now, that's not everyone. Some people will have very different and unusual symptoms, which is why I tell people anything that's new and different, let us know. But the most common would be the abdominal symptoms.
Okay. So kind of knowing your body best and what's normal for you, and then flagging those abdominal symptoms. Okay.
Yeah.
Another question, and this came up in the chat, and this comes up a lot in our other events. Why isn't there CA-125 monitoring for those who have a family history of ovarian cancer, given how sneaky this disease is and the lack of other clear symptoms/signals?
That is an absolutely excellent question. And I want to say maybe 15 or 20 years ago, the oncology community was very, very, very hopeful that CA-125 would be a good way of monitoring. And they've actually done huge, huge studies, like thousands of women, both in the UK and the US, looking to see if routine ultrasound scans, routine physical exams, routine CA-125s, if these could catch ovarian cancer early. And very, very sadly, they cannot. There is no effective way to screen for ovarian cancer. They took women, they had them do CA-125s every 6 months for years. It did not change the number of ovarian cancer diagnoses, and it did not cause them to be diagnosed at an earlier stage. It made fundamentally no difference, which is sad because it would be a very easy way to screen, but unfortunately it doesn't work.
Okay, thanks for that. There seems to just be a little bit of confusion around why delaying treatment does not affect outcomes in the recurrence. Is there any way you could clarify that in a bit more detail for people?
Sure, I can certainly try. So this is only true, I'm going to put this out there, this is only true in the recurrent setting. So in the primary setting, deferring treatment definitely affects outcomes. In the recurrent setting, as we were talking about, it's a little bit different. We don't anticipate that we're going to be able to get rid of the cancer permanently. We by and large, once a cancer has recurred, and this is true of every cancer, we've lost our ability to cure that cancer. We can treat it, we can improve quality of life, we can prolong life, but we are unlikely to ever cure it. And so in that situation, when we are no longer aggressively going for cure, we know that it's fine to live with the cancer. You can live with the cancer, and as long as it's not causing you significant symptoms, it's not going to make you die any faster from your cancer. If you never treated it, obviously that's very different. But if you're planning at some point to start treatment, but right now you feel great, or right now you have a vacation that you really want to go on, or something else life important, and you want to bump it to later, your cancer will respond the same if you treat it on the day you're diagnosed as if you treat it 6 months later. The only difference potentially is that you might not be as strong if you've been living with your cancer for 6 months without any treatment. So that's the balance there.
So that's really helpful. Thank you. One of the questions is, why is there such a high rate of recurrence?
That is a tricky question to answer. The problem with ovarian cancer, specifically high-grade serous ovarian cancer, is that it spreads what we call peritoneally, which means that it doesn't just start as a blob and grow as one blob, so you get a big lump in only one place. It starts as a very small little tumor in the ovary, and then it starts sprinkling cells all over the lining of the abdomen and the bowels and any other organs that are in your abdomen. And so you get these tiny little deposits absolutely everywhere throughout the abdomen. And we go in there and try and get it all out with surgery, and we can remove what we can see, but you can't remove microscopic cancer cells because I can't see them to remove them. And so that's why we use chemotherapy to try and get rid of all of those microscopic cancer cells. But chemotherapy is not perfect, unfortunately. And it's the fact that it spreads so diffusely so early in the disease that we end up with high recurrence rates.
Okay, thank you for that. Okay, so someone has asked about how many times someone can take chemo and how many recurrences can actually occur.
A lot.
Okay.
Is the somewhat flippant answer there. It obviously depends very much on the person and how well they are and how well they were before getting cancer and how long they have between their cancer treatments. I have treated people who have had 10 or more lines of chemotherapy, and they do get harder. You know, the more chemotherapy you have, the harder it gets. We often have to switch chemotherapy drugs because also your bone marrow gets a little bit tired. It stops producing your hemoglobin and your red blood cells and your white blood cells as well as it otherwise would. So sometimes that can be a limiting factor. You're more likely to have allergic reactions when you get to the 10th line or the 10th time you're getting the same chemotherapy as the first time you're getting it. So there are things that limit it and cause us to have to change the treatment. But as long as you are strong enough for chemo and interested in chemo, and there's a drug that your cancer is still sensitive to, you can have chemo.
Okay, that's great.
Mhm.
So I feel like I'm just peppering you with questions, but there's so many that are coming in and we do have the time right now.
All right, go ahead.
So earlier, Dr. Roberts mentioned respiratory symptoms. Can you be a bit more specific about those symptoms?
Sure. So some people will develop often more commonly with their initial presentation, but sometimes with recurrence. Similarly to the way that you can get ascites and the fluid in the belly, you can get fluid around the lung. It's called a pleural effusion. It's not in the lung, but it's around the lung. And that can cause shortness of breath. It can cause a dry cough. Most commonly, people will notice it initially as, well, now it's really hard to go up a flight of stairs, or I used to be able to walk for 5K and now I can only walk for 1 before I start getting really short of breath. It's most commonly a sort of slowly progressive shortness of breath that we see.
Okay, that's great. That's really helpful. So we've talked a little bit already about how to watch for recurrence, but someone has more specifically asked, I think this is a good question about the best way to watch for recurrence, because on Lynparza, many of the side effects could also be the symptoms of recurrence, like the nausea and the fatigue. So how would you advise people kind of understanding, kind of delineating the difference of what's being caused by maybe their medication and what could be a sign of a recurrence?
Excellent question. So being on Lynparza is a little bit different because you are on treatment. And when you are on treatment, we tend to monitor a little bit more carefully in terms of doing blood work and things like this, because you are on a treatment that is potentially harmful, right? There are side effects associated with any treatment that we use. So most people will still be getting routine CA-125s on Lynparza or on any maintenance therapy. Now, it's not done every single time you get blood work, but usually about once every 3 months. And so that's one way that we're keeping track on things when you're on a maintenance therapy. The other thing, when you're asking about, the symptoms being very similar, you're absolutely right, they are. And so typically what I tell people is attribute whatever you feel in the first 6 weeks of being on Lynparza to the Lynparza. Let yourself get a baseline about how you feel on this drug, and then you know how you feel. And if how you feel on this drug changes, so if the way you felt at 6 weeks, suddenly now 6 months later on the Lynparza, you feel much worse, that shouldn't really happen. Usually the way you feel on that particular drug, once you get a baseline, which typically takes about 4 to 6 weeks, that's how you're going to feel. And if that starts to feel worse, things start to get persistently, slowly, gradually worse, that's when you want to check it out.
Okay, that makes sense. So another question: how likely, how likely is recurrence? If I think that I'm kind of rewording the question. I hope I don't change the meaning. But if the original ovarian cancer is caught in early stages, how likely is the recurrence, especially if it's localized to the ovary?
So significantly less likely. So the rates of cure, which means no recurrence, increase the earlier stage you have. So again, it depends upon the type of the cancer, exactly what stage it is, but overall a stage 1 ovarian cancer, so confined to the ovary, has about an 80 to 90% cure rate, which means if you flip that, about a 10 to 20% recurrence rate. And so depends is the short answer, but certainly having a cancer that's confined to the ovary that hasn't spread is a very good prognosis, much less chance of having a recurrence.
Okay. So you mentioned that the kind of follow-up protocol is going to vary across the country. Do you know why that variation exists? Are there standards or kind of, you know, gold standard approaches to this kind of thing?
Tricky questions. I like it. So the gold standard follow-up is something that you will get absolutely everywhere, which is a every 3-month history and physical. That is the gold standard follow-up for an ovarian cancer, and you will get that everywhere, with the exception of the fact that you may not be getting the physical right now because of COVID. However, if you had symptoms, someone would bring you in and then you would get your physical. So that is what should be happening, and that is happening. Why things are different across provinces is a very frustrating thing to be in the healthcare system and practicing in it, is because healthcare is provincially mandated, and that means that the provinces are funded differently. What the physicians in every province and cancer care has access to is different in every province, and what is prioritized is different in every province. And that's not a very satisfactory answer. I recognize that, but unfortunately that's
True.
That's true. That's where we are. And it can differ within provinces as well. So I worked in Oshawa, just outside of Toronto, before moving to Winnipeg. And the way we practiced in Oshawa and how we followed up patients was different than how Princess Margaret in downtown Toronto managed patients, because they had more resources and they had more access to things than we did in a community hospital. It's not satisfying, but it is what it is. But everyone is getting the standard of care. There is no actual benefit to getting routine scans or routine CA-125s. So you're not missing anything. It's just that is why it differs.
Okay. So just kind of switching gears here for a second. Do you need to take a breath? I'm just kind of
I'm all right.
Okay.
Ask Terri something.
All right, Terri, we're going to talk about a different type of blood test. You could either of you jump in, but one person did mention that they're actually not getting the CA-125 blood test, that they're getting something called AFP. Is that something you can speak to at all if people are wondering what AFP is?
Yes, that is for a very different type of ovarian cancer, for typically going to be for something called a yolk sac tumor or a teratoma, which are what we call germ cell tumors. So most women, particularly women who get diagnosed with ovarian cancer postmenopausally, which is most women, have what we call an epithelial ovarian cancer. It comes from the lining of the ovary, around the outside of the ovary. There are rarer forms of ovarian cancer that come from the actual meat of the ovary, what we call the stroma. They're either germ cell tumors or sex cord stromal cell tumors. They're much rarer and they have very different markers and they behave very differently. They tend to do very well. The cure rates for those cancers are very high, but we do follow them, some specific types, with AFP. So that's not something that we would use for the more common types of ovarian cancer.
Okay. That's really helpful. Thank you. I hadn't heard of AFP before, so I really wanted you to answer that one. Okay, I'm trying to group a few questions together here, just around kind of the PARP inhibitors. We were talking about, I think, Lynparza before. Can we assume that you were talking about both PARP inhibitors in terms of that?
In terms of the monitoring, yes, they do have slightly different side effects, but yeah, by and large, 4 to 6 weeks, you're going to feel how you'll feel for the rest of the time. And
okay, and to kind of piggyback on that question, there's some questions about how long you can stay on it. How effective are they, and how long can you stay on them?
How long you can stay on them depends upon the drug, and it depends upon the situation in which you are taking them. So you can take a PARP inhibitor in the first line. So the first time you have treatment, we put you on it as a maintenance therapy, or if you didn't have it in the first line, you can take it with your first recurrence, so in the second line setting. The studies that we have the most data for are for Lynparza, and Lynparza was so effective that they haven't actually been able to publish the overall survival data yet, because people are living for too long, which is a good thing, but it makes answering some of these questions a little bit challenging. So in terms of if you are taking a PARP inhibitor, specifically Lynparza, in the recurrent setting, so you have had your first treatment, you did not get a PARP inhibitor, you recurred, the length of time you can be on it is indefinite. you could stay on it forever. Now, there may not be that much of a point because we consider a person cured after 5 years. So whether you need to stay on it forever, we don't actually know. So we have some people who say, I'm done with taking medications, I'm going to stop at 5 years. We have some people who continue on with it. We talked about someone recently in Winnipeg who's starting year 7 and doing very well and is perfectly happy to keep going on with it. That's in the recurrent setting. In the upfront setting, it's a bit different because the trials that they ran, depending upon which drug you're looking at, were only for either 2 or 3 years. And so we only have funding for either 2 or 3 years because that was what was in the studies. So most places in Canada, if you are taking a PARP inhibitor after your very first treatment, you will be on it for either 2 or 3 years, depending upon the drug you're on.
Okay. Someone asked earlier, I'm just trying to find it, but I can't find it now, about, understanding that the, first line treatment is curative intent, and then in recurrence, it's more of a chronic disease management. But the question was, have you ever seen someone be cured from a recurrence? That's a tricky question.
I mean, I guess, yes, I have seen people have a recurrence and then have 5 years of cancer-free time.
Okay.
Based on what I know of cancer, I don't believe that that's truly a cure. In the back of my mind, I anticipate that at some point it's going to come back and they're just having a really fabulously long cancer-free time.
Mhm.
But given that I said a cure is 5 years cancer-free, I guess technically I have to say yes. I boxed myself into a corner on that
Yeah,
one.
we trapped you a little bit there. Sorry about that.
Yeah.
Okay. Terri, sorry, I don't mean to kind of take over here. Terri, did you want to ask any questions that might be coming up for you as we go, or anything you'd like to share as we're kind of going through this?
No,
Not to put you on the spot. Okay.
I'm just listening and enjoying it. No, I don't have anything new coming up.
Okay, great. Someone has asked about qualifying for medical assistance in dying for MAID. I'm not sure if this is something you could speak to, or maybe something we can follow up on later.
Oh, sure, I can answer that. So again, it is a little bit provincial, but by and large, the guidelines for MAID are federally mandated. There's a major federal court. So it is something I like to tell people, this is something that you can search out yourself. If you Google MAID in your province, they are almost always self-referrals. You do not need your oncologist to refer you for MAID. And I say that because some people are not supportive of MAID, and that's totally fine. But if it's something you're interested in, look it up yourself. And so in terms of when you qualify, you need to have a life-limiting illness, and you need to have something that says this is not acceptable to you anymore, whether that's mental suffering, physical suffering, whatever it is. You can't be feeling absolutely 100% totally fine with no concerns and say, sign me up. There has to be some sort of suffering. And they're very, very loose with the definition of what this is. So for most people who are planning to go forward with treatment of the primary diagnosis of ovarian cancer, they would not qualify for MAID at that point in time because we are treating with curative intent. Now, that's not true for everyone. Things are a little bit different. There are times where even upfront, we are not treating it with curative intent. And so certainly it's an option. But definitely with a recurrence, if it was something you wished to proceed with or investigate, I think in most provinces you would qualify at that point.
Okay. Yeah, thank you. It might feel like I'm jumping around a little bit with topics. It's just because questions are kind of coming in as we go. And I do apologize if I'm missing some, and we will circle back later. But one question I do get a lot from people is about immunotherapy and if that's an option for ovarian cancer.
Right now, no, is the short answer. There is no immunotherapy approved or covered in Canada for ovarian cancer. And realistically, the trials for immunotherapy in ovarian cancer have actually been fairly disappointing. It has not been shown to be particularly effective yet. I'm sure they'll find something eventually. We haven't found it yet. There are, I believe, still some clinical trials running or getting started, primarily in Toronto or Montreal, that are looking at immunotherapy in ovarian cancer, but they're very much trials based at this point. And clinical trials also, like everything else, took a little bit of a lull during COVID. So everything's just getting back up and running at this point. But the short answer is no, there's no immunotherapy for ovarian cancer. There doesn't appear to be anything shortly coming down the pipeline either. It hasn't proved to be particularly effective, unfortunately.
Okay, so in kind of keeping on that different types of treatment theme, can radiation be used as a treatment in recurrence?
That depends again on the type of the cancer. There are 1 or 2 types of ovarian cancer where we will use radiation for treatment. By and large, high-grade serous, the sort of standard ovarian cancer, we do not use radiation therapy as a recurrence for a recurrence treatment because radiation is a local treatment. So radiation will treat a spot of cancer. Unfortunately, ovarian cancer tends to have multiple spots that are scattered all over the place. So radiation doesn't really target it very well. However, if there's a particular spot that's causing pain, for instance, or if there's a spot in the bone, or certainly one would hope not, but if there's cancer in the brain, radiation is used for all of those types of sites. So there are circumstances in which we use it, but it tends to be very specific and not the first thing we go to.
Okay, I'm aware of the time. I'm going to try to combine a few questions together and give you just 2 more questions, and then we're going to let you off the hook here. So I'm going to try to bring a few together here, which is around genetic mutations and PARP inhibitors. A theme I'm kind of seeing is, does a genetic mutation, specifically the BRCA mutations coming up, is that going to change how effective a PARP inhibitor is for you? And how likely a recurrence might be? That's the other question there as well.
So the PARP inhibitors have been shown to be profoundly effective in patients who have BRCA mutations. The BRCA mutations, those patients, whether you have what we call a germline BRCA mutation, so that's a mutation that is inherited and you carry in your bloodstream, or a somatic BRCA mutation, which is you didn't inherit the mutation, you won't pass it on, but your tumor specifically has the mutation. Those patients do very well with PARP inhibitors. They are the patients for whom the overall survival has been increased by years and years and years in the trials, and we haven't figured out by how much yet, because they're still living well and doing so well. That's not to say that the PARP inhibitors are not helpful for patients who do not have a BRCA mutation. They are still helpful, but the magnitude of benefit is not nearly as significant as those who have a BRCA mutation. So in terms of recurrence risk, if you have a BRCA mutation and you are on a PARP inhibitor, yes, your recurrence risk is definitely much lower than it would be if you had a BRCA mutation and were not on a PARP inhibitor, or if you didn't have a BRCA mutation at all.
Okay, that makes a lot of sense. And I'm going to finish off with one question here. And I just want everyone whose questions we didn't get to. I see them, I'm reading them. I don't want you to feel like you're being ignored. And we are going to try to follow up and get as many of these answered as possible. And Dr. Roberts, not to paint you into a corner here, but your thing about 5 years with no recurrence, you would consider it a cured patient. Do all gyne-oncologists feel that way?
I can't speak for all gyne-oncologists, but I would expect so. Sort of this standard definition of a cure of cancer in most cancers, but certainly most gynecologic cancers, is 5 years cancer-free. Every trial looks at 5-year overall survival, which like cancer-free overall survival. And that's broadly speaking the definition we use. Again, there are, depending upon your cancer subtype, a few exceptions, but by and large, if you have your primary treatment and have had 5 years of follow-up with cancer care, you are going to be discharged at that point. And that's, again, minus a few very small exceptions, that's pretty standard. So that's what we're aiming for.
Okay, that's great. Thank you so much. I'd like to thank both of you, Dr. Roberts and Terri, for sharing your obvious wisdom, your tips and tricks, your advice, and all of your knowledge with us this evening. We're so grateful. And I'll let you off the hook now. You guys can both take a breath. And I just want to go over one more item before we move on to our next session. So the Every Woman Studied identified many gaps in our healthcare system and revealed more about the emotional experiences of people affected by ovarian cancer. So in response to those findings, we're in the process of developing a set of tools that are going to enable those affected by ovarian cancer to make informed decisions about their care. All the tools are being developed in collaboration with a diverse group of experts, including patients. And we're using design frameworks to engage as many different types of people as possible. So including people with different levels of education and language barriers and neurodivergence and learning disabilities. We know that many of these issues that the tools are going to aim to address are really big healthcare system issues. So at Ovarian Cancer Canada, we are working to better understand these larger system level issues so that we can effectively advocate for change. But while we do so, we're hoping that these tools will empower patients and their loved ones to advocate for their own care. So as it relates to this session that we've just had, one of the tools in development is an understanding recurrence monitoring tool. So we know from the results, again, from the Every Woman study, that fear of recurrence is the greatest emotional challenge among people affected by ovarian cancer. So this tool will hopefully help people to better understand their follow-up care plans, how they're going to be monitored for recurrence, and will support these effective conversations with their healthcare team about recurrence monitoring. So if you have any questions about that tool, or if you want to provide your input into the development of that tool, please get in touch with me. I'll put my email address in the chat, and I'd be happy to talk with you about that further. And I'll just tell you now, my email address is aross@ovariancanada.org. So again, a huge thank you to Dr. Roberts and to Terri. And Steph, are we good to move on then to our next session?